Good morning, Mr. Rains. We are happy to have you here with us today.
I can't hear a word she's saying.
Good morning.
When you're ready, go ahead and if you would introduce yourself, please let us know your position at OHCA and a little bit about your background, if you would, please.
Of course. So thanks for having me. I hope everyone had a wonderful weekend and enjoyed the great weather out there. So my name is Trayla Rains. I'm the Deputy State Medicaid Director at the Healthcare Authority.
Unfortunately, we're not able to hear you right now. If you would try again, that would be great.
Can you hear me now?
Not yet.
So someone in the chat said they can hear me.
Okay, somebody says that they're able to hear him.
I can hear him.
Okay, good, because I'm not on mute, so I wanted to make sure.
Good job. Okay, I have settings changed now and I can hear you clearly. Thank you.
Okay, awesome. So I'm Trayla Rains, the Deputy State Medicaid Director at the Oklahoma Healthcare Authority. As far as background, I've been back at the Healthcare Authority for just over a year now. Prior to that, I was a Senior Director at the Oklahoma Department of Mental Health and Substance Abuse Services. Was there for 7 years. Prior to that, I actually spent my first 7 years in state service at the Healthcare Authority. So a little over 16 years in the Medicaid world in Oklahoma. So I wanted to come on this morning, and thanks for inviting me to have this opportunity to talk to you all. We've done a couple of town halls now across the state. We plan to do more. So I would just encourage you all, as you see those, go to our website or check us out on Twitter and Facebook and sign up for those and submit questions that way. Because a lot of the stuff, I'll be going over to this morning, we're going over in those forums as well. So I wanted to give just an overall update as we transition to third-party managed care in Oklahoma. I'll start with a timeline. So we did award our bids to 4 medical plans and 3 dental plans. The 4 medical plans also include a specialty plan, which is designed specifically for kiddos in the custody of the state, either through child welfare or juvenile justice. All of our plans will be statewide. So if you recall, or were around or heard stories about managed care in Oklahoma in the late 90s, early 2000s, it was a very different model. It was more regionalized, with the managed care entities having a regional approach, mostly in the metro areas of Oklahoma. And then the Healthcare Authority directly administered the benefit for the rural areas. So all of our plans this time will have a statewide presence, including the specialty plan. Our vendors are Humana, Healthy Horizons, Oklahoma Complete Health, and Oklahoma Complete will also administer the Children's Specialty Plan. And we have Blue Cross Blue Shield and Humana, and we'll have 3 dental plans, which is MCNA of Oklahoma, Liberty Dental, and DentaQuest. So as far as timeline goes, the first notice that members will get around this topic will be July 1st, and that's going to let them know that they will have the opportunity beginning August 1st to begin choosing from the 4 medical plans or the 3 dental plans. They'll have from August 1st to September the 10th to actually make a choice of one of those vendors. If they haven't chosen, then over the few days following the 10th, we'll do auto assignment to a plan, which is just going to be a very basic round robin algorithm, to where we will assign all roughly everyone that hasn't chosen, which the pool of Sooner Select eligibles is around 700,000 individuals. We'll assign those all to a managed care plan, but that does not mean that the member is locked in at that point. They technically will then have 90 days to, after they get their notice of plan assignment, let's say a member is like, I don't want to go to Humana, or I don't want to go to Oklahoma Complete Health. They'll have 90 days to call or go to mysoonercare.org and change their plan that they would like to use. We will have trained choice counselors within the Healthcare Authority, as well as our Tier 1 call center staff that will be trained on the various plan benefits. They'll have benefit comparison guides so that they can talk to consumers as they call and educate them around which plans does their PCP belong to, which plan does their specialist belong to, what value added services each one of them offer, so they can really make an informed decision when they choose that plan. So by the time we've assigned everyone that's eligible for Sooner Select will be aligned with the plan October 1st of this year. So what that means in terms of provider payments is that all provider payments for the 700 members that are going to Sooner Select will then go through the various plans. That means that you will either be an in-network provider with the plan if you've chosen to enroll with them, or an out-of-network. These plans, as my guess is, they're probably reaching out to you now to build their adequate networks. And so I would encourage everyone, to ask those plans the specific questions around reimbursement and information about prior authorizations. What I will say is there are certain fee schedules that we set floors on and others we didn't, but we've received confirmation from the plans that they all plan to use 100% of the Medicaid fee schedule currently. So I've heard from, for example, at town hall last week, I heard anywhere from providers are being told that rates will be cut by 20 to 60%. And as far as I've talked to the plans, it's not true. They've all indicated that they plan to use 100% of the Medicaid fee schedule. There may be some items around labs or durable medical equipment that may be a little less, but not services that would be offered by your group or the behavioral health group. In fact, for behavioral health services, we did set a floor on those, since those are below national average for a percentage of Medicare already, and we didn't want them to go any lower, as well as our safety net providers like rural health centers, federally qualified health centers, and certified community behavioral health clinics. We've set floors for those as well. So I would encourage you, if you hear stuff like that from the field, please feel free to reach out to me. What I would say is, I know it's a daunting document. The RFP is well over 500 pages, but if you do a quick word search around prior authorization or physical therapy, for example, it'll take you right to the provisions that deal with that. 9 times out of 10, when a provider comes to me and is concerned about, PA turnaround times, for example, or medical necessity criteria, 9 times out of 10, we addressed it in the RFP, because we know that we run a pretty tight sooner care program. We know that we pay quickly. We know that our PA turnarounds are fairly decent compared to national averages. And we want our providers to experience the same with our managed care partners. So we built a lot of protections into the RFP that protect things like that. Now, I will say I've heard questions around timely payment, for example, because we all know if you get your claims in by Wednesday, you're paid the next Wednesday. Federally, we have 45 days to pay, and a lot of states go right up to that 45 days. One of the things we learned from managed care the first time was that if you wait 45 days to pay a claim, you're not going to have an adequate network. And that's what we saw a lot during the 90s with managed care. So this time we set a max as the plans have 14 days to pay. So it's not, it's very possible they could pay more often. They could pay within a week, but we set that ceiling at 14 days. We didn't want them to go up to 45, because we learned our lesson the first time we tried managed care. And that was really something that the healthcare authority, when they brought it back in-house, we went to that week because we knew we had to build our providers back up, as well as getting our rates back to close to 100% of the Medicare fee schedule. So a lot of those things we've really tried to protect as we wrote the RFP, and we saw that documented in the responses to the RFP. What I would say too is there's concern around the various provider types, because commercial insurance doesn't necessarily contract with everyone that Sooner Care does. We wrote into the RFP that if we provide a service now and we contract with a professional or paraprofessional currently, the managed care plan also has to acknowledge that individual provider type. Now, what I'm hearing from the field is there have been some contracting agents from various managed care plans reach out and say, I'll just use an example, like licensure candidates for behavioral health, for example. They will say, we don't contract with those, when in fact they do. And so you have to remember that we just went live, March 1st. And so these plans are building out their Oklahoma staff that are specific to Oklahoma. And so they don't have those call centers on the ground yet. And so they're using national contracting agents who a lot of times are working with multiple states. And so sometimes, unfortunately, our providers are going to get responses that are not specific to Oklahoma, because not other states have been as strict in their RFP requirements as we have, and they're just not up to speed yet. So again, as you hear those, please feel free to reach out to our provider services or me directly, because as soon as I hear that, I'm emailing the CEOs of the various plans saying, you're putting out wrong information and you're making everyone scared, please stop. And then we've already heard about call centers sending them to the wrong places. long wait times. And so we are addressing that. In fact, at the last town hall, we heard that I think it was Humana was sending folks to a call center in the Philippines. Well, it turns out they have a Medicare contracted call center in the Philippines. And so we've already they've created an Oklahoma specific email address. We verified it. Oklahoma staff have started secret shopping these call centers to see, what are the wait times, what's the provider experience like, so we can directly follow up with personal experiences with those plans. What I will say is a lot of responses I'm getting from providers is a generalized fear and anxiety, which I completely understand, because this is your business, is your livelihood, and you take care of our members, and we appreciate you for that. And it's change. But what I'm hearing a lot of is experiences with these companies from a commercial payer experience. What I would say is this is not commercial insurance. And so if you have worked with, for example, our two state, we have United and Blue Cross Blue Shield that have various Medicare plans or commercial insurance plans, it's going to be very different from a managed care experience through the Medicaid benefit, mainly because we oversee them. So we're not simply handing the keys to the castle away to these plans and letting them go unchecked. The RFP, like I said, is very specific in their requirements. They have voluminous reporting requirements that we are creating for them. For example, around, I think one of the concerns is prior authorization times. Some commercial insurance might take 30 to 45 days to process authorization. What we will say is that's not okay for the healthcare authority. And so we will see reports on various intervals. We'll get weekly reports on things, monthly, annually, semi-annually. And we will look at things like PA turnaround times, and we have specified timelines for that. Some, are 24-hour turnarounds, others 48, 72. And so we will track that. And if we see that PAs are taking longer than the requirements, we have specified penalties for that within the RFP. Of course, it's going to be progressive penalties, progressive disciplines, if you will. So like for some things, if you don't submit a report on time, it's, I think, $5,000 a day for each claim that you don't submit a report on. And so we really wanted to have a lot of teeth involved if we needed to follow up with these plans to say that, this affects our providers, which affects the care that our members receive. And we want to be able to take action on that quickly. For example, we've already had calls with the plans. So there's been several reports that have been due the last 2 Fridays, and there's been a couple that have not, been timely. And so we've already had calls with them and let them know that, okay, we're having a call with you this time. It was our first time to go through this process. The next step will be a letter. The next step will be financial penalties. And so we're being very clear from the get-go on what our expectations are. I know there's also some questions I've been hearing around credentialing and how you contract with the various plans. Unfortunately, that is one of those things that's going to be a little bit more administratively burdensome for providers. However, I will say that despite these plans technically being competitors, they're all working well together to make sure that the processes for our providers are as seamless and efficient as possible. One of those ways is credentialing. So we have required that they use a uniform credentialing application that is actually created by the health department and is required for any commercial plan or managed care plan in the state. So they all have to use that. But then technically they can say, well, Blue Cross wants these 3 questions in addition to the form, and Humana may want these 4 additional criteria. So all of our plans are actually working together to make sure that they're asking the same things and that they're not giving you each different forms. And so that way, technically, once you filled out one credentialing form, it would work for all the plans. You still have to come in through the healthcare authority front door. So we will still do our federally required screenings. You will apply through the healthcare authority, and anyone vetted through the healthcare authority is now in the pool to be chosen for contract by the plans. So you'll still have to do that piece. And so the plans are also verifying that they're not requiring information or documentation that you already provided to us, for example. So they are working together to make sure that process is as easy as possible. Now, I will say on the billing piece, there will be billing through the various different portals. And so if you have clients that you see and you are contracted with 4 plans, there's going to be billing through 4 different portals. You will still be able to check eligibility through the healthcare authority, through that portal that you're accustomed to currently. Also, if you are serving individuals that are on Sooner Care because of a disability, or you're seeing Sooner Care kids, those will still be, I'm sorry, TEFRA kids, those will still be directly administered by the healthcare authority. So any claims for those kiddos would come through us. As a refresher, those going to Sooner Select are only our expansion adults, pregnant women, and non-disabled kids. If you're seeing kids in the care of DHS or juvenile justice, that will go through Oklahoma Complete Health, as they'll be a member of the Specialty Children's Plan. We don't expect to see dramatic drops in units authorized, for example. We've set the OHCA criteria for medical necessity, prior authorization turnaround, unit caps. We've set what we require as a floor. So they can provide more limits in general, or they can provide less limits on some things, but it has to be approved by us and with input from our providers. So there's not going to be using any criteria or limits on services that hasn't been vetted and approved by the healthcare authority. As I mentioned earlier, we know through experience what works for our providers and what doesn't. And so we'll have a handle on all of that. So I'm happy to take, I know I received some questions Julia sent last week. I think I tried to touch on most of them on my overall, but happy to take individual questions now or anything to follow up on what I've already mentioned.
Thank you, Trailer. There are some good questions in the chat. Can you access those currently?
Let's see.
And a lot of them have to do with timelines and making sure that we have our continuity of care. A large population of our clientele are going to be children that have a medical diagnosis. And so we want to make sure that all of our T's are crossed and I's dotted before that transition time. If you could go over those dates again, and then because we will need to be enrolled with OHCA already and then signing contracts, there are a couple of questions about that time frame. And if we have authorizations for services through the August or October days currently, then will those be impacted? And should we plan on doing progress reports and reassessments for the new managed care to authorize services?
Very good question. So the plans will actually have to demonstrate to us, they're currently demonstrating on a weekly basis, actually, an adequate network. And so they have a requirement. There's certain time and distance standards within the RFP. So for example, this may not be accurate, but like for primary care, I think we say you have to have one within 25 miles of the member. And then there's also a time distance too, like, or 20 minutes, for example. And so they have to submit geo maps to us on a weekly basis, showing their network and that it's adequate and that they're meeting those time and distance standards. And so part of that will be around, they need to provide adequate rates. They need to provide time turnarounds that are good for y'all and work for y'all in order to sign with that. So I would say, I say that to mean that they're building their networks now. And so as they reach out to you, I would encourage you to have those conversations with the plans and go ahead and sign up with them. I think they have to demonstrate network adequacy to us by June or early July. And so they're working on those uniform credentialing applications. And so as they reach out to you, I would just encourage you to ask questions of them. Again, if you have, a hard time getting through to them or responding, let me know. And so I can work with their call centers to help. As far as the PAs transitioning, we're already working with the plans on what that looks like. Per the RFP, they have to honor open PAs for 90 days. And so that's 90 days post 10/1 that we will send over our prior authorization files, and essentially they have to honor that for 90 days. And so they'll waive all of their PA requirements for that initial time frame. And then we'll start working with you on, does the information you provided suffice for PAs? Is there anything additional? But we're allowing plenty of time for that, for you to, complete those new assessments if you need to, or update an assessment that's already been previously done. They aren't going to want you to provide any duplicate or additional services that's going to cost additional money. So they'll, build upon what you've already done would be my expectation. Now, I will say there will be a requirement that individuals coming into a managed care plan will be screened by the plan on some level. That's not going to be full assessments on their level. It's going to be very basic but comprehensive health risk screenings to try to identify any issues that have not been identified by a primary care provider or specialist. You know, there was concern by a lady at the, and a very legitimate concern at the town hall around, they're fearful. I know there's a general fear of individuals not getting enough services or not getting enough prior authorization or being steered away from certain services in lieu of other things. What I will say is, we really believe that these initial health risk screenings will actually identify the need for services earlier in order to address them on a more preventive nature, rather than getting a lot of these kiddos kind of at crisis mode, where we're then working to resolve a crisis and we're trying to undo years of things that we could have addressed a lot earlier. So I'm really hopeful in that by doing these initial screenings, we're going to get them into your door a lot sooner. We're going to see a lot more services that actually make the overall person better, because they're only going to achieve savings by helping these individuals get better and need services less, not through just, you know, unilaterally cutting authorization limits for no reason, because that's going to show up in higher cost elsewhere. Someone's going to go to a hospital then if they're not receiving these services, or an ER, and that's going to cost the plan more and reduce their opportunity for savings. Let me see if I can scroll down.
That makes sense, but we've had some concerns that currently we have a good system working with OHCA, who have therapy providers doing the auth reviews, so that they really understand the reports and they understand the medical necessity that's written into the reports. We have experience with commercial insurance doing reviews by non-qualified staff, or who are not at all related to the therapy world, giving, you know, a lot of time and administrative effort to go back and forth and provide details that they might need otherwise. So as far as administrative duties, do you have that conversation with the MCOs going regarding the authorization process?
We do. So again, just to highlight the difference between a managed care plan and a commercial plan, because some are using the term interchangeably. A commercial plan really doesn't have that oversight by anyone except for the insurance department. So they aren't being overseen and held accountable by the Medicaid agency. And so, in all transparency, I'm already seeing some of the plans that we're working with that have commercial lines. They're really not used to that oversight level, and I'm seeing that already. And so that's why we're taking a very early and strong approach with corrective action, because we want to get them accustomed to, we're watching you now, and here's our requirements. I will say around utilization management, we had very specific requirements for review staff, what we expect for those review staff, and we are looking at their staffing on a weekly basis to make sure they've hired Oklahoma specific staff that are trained and understand each provider type that we work with. Most of the time we have our requirements emulate those that we use internally. So if you're authorizing behavioral health service, we want to see a licensed individual doing that at the plan. Same for PTOT and ST. And so as we see that not happening, that's an opportunity for us to follow up with the plans, because we understand that it makes a difference who's reviewing your claims and who's reviewing your notes.
There's a question in the chat regarding those time and distance standards you had mentioned, providers needing to be within a certain location zone, geo zone of the members. A quick question about that. Are those specialty specific? So would it be, a clinic in general that needs to be that close, or would it be specific PT or pediatric PT specifically?
It's been a second since I've looked at them on specifically, but I will say I know there's for sure we have like primary care, specialty care, and like hospital care. I don't know that we drill into individual specialties, or rather we just have specialists group into a group. But I can refresh on that after this call and get you that in writing for sure.
That would be awesome. And additionally, one of the concerns has been, would there be caps on the providers that are accepted in network with the MCOs?
I really don't expect that to be the case. So we know that as a state, we're fairly underserved in all provider areas and specialties. And again, the plans will actually have to create a network that, in my mind, is probably more robust than what we currently have as a sooner care program. So it's going to be challenging for these plans, especially in the western areas of the state and the more frontier areas up in Diamond and Woodward, that currently, I don't know that the healthcare authority meets the time and distance standards that we've required for the managed care plan. So I would highly doubt that there's going to be caps on plans. I would guess it's going to be the opposite, and that there's going to be continual recruitment efforts by the plans to maintain their network.
We've currently received multiple forms of contract requests from the MCO groups, starting last fall as there were bids being formed prior to the contracts being selected. And then this spring, actually in the last month, we've received, even from the same companies, multiple forms of contracts. So as they are updating things and negotiations, I guess, are being made, we're receiving more paperwork. So if you could help us as providers and as clinic owners kind of navigate this process with a timeline, and then best practice, how can we go forward with making sure that all of the credentialing information and background information is provided for the companies that were selected through the contract with OHCA? Well, at least once correctly, but when we're provided the contract paperwork and then the deadline for it to be turned in is literally 4 days from the date of receipt of the contract. So we've had some experiences with a very short turnaround requested, but then additionally, the RFPs aren't complete in the packet, or the contract provider manual isn't even available yet. So will clinics be penalized, or is there a chance that we might miss out on those important continuity of care timelines going forward? Is there a recommendation that you could help us with?
Yeah, I could definitely communicate that back to the plans. Again, what I'm seeing is what's unfortunate is that first impressions are sometimes the only impressions you get. And I feel like they're starting off on the wrong foot already with the various contracting issues that I'm seeing. And it's unfortunate because in my experience with them already, I really do have, I have personal excitement around what I think they can offer the state. And offer our members and offer our providers. And so it's unfortunate that we're starting off on the wrong foot with some of these issues. And so I will continue to take these back to the CEOs of the plans. We meet with them. I meet with the CEOs at least once weekly alone with me and them and our Medicaid director to talk through issues just like this. We have 10 implementation work groups around various topics that we meet. Each work group meets for at least an hour a week, and that's OHCA staff along with plan staff to make sure we're working through all this. We have a provider network specific work group where we can address issues like this. And a lot of the times when I've addressed it, the Oklahoma staff are mortified and they reach out to their national staff and get it fixed. And so it's I've yet to roll out any large project where there's not some hiccups. And unfortunately, I think this is one of those initial hiccups that we're trying to work through. But it should definitely be as streamlined as possible. And what I would say to y'all as providers is, kind of hold the cards here. So yes, we want to make sure you are still able to serve senior care members October 1st, but they need you to build an adequate network. And so don't be afraid to talk to the plan administrator, say you want to speak to a manager, talk through issues around reimbursement, talk through issues as well as PA times, and say what's important to you as a provider. Also, I would say that all the plans are going to have various advisory committees made up of senior care members, as well as our various providers and specialty types. And so feel free to talk to your plan about, hey, how do I get on one of these advisory committees? And how can my voice be heard as you develop policies internally? Because there's going to be that continuous feedback loop, not only from the healthcare authority, but also from providers and members on these advisories within each of the plans.
We have a comment that a contract was received with Oklahoma Complete Health. And I was just wondering, is that one of the Sooner Select plans?
Mm-hmm. It is.
Okay.
Yeah, they are a Sooner Select for general population, and they also hold a specialty contract for kids in custody.
Okay. The contract mentioned they did actually include some RFP details, and it said therapies will be paid at 80% of the Medicaid current rate. So we were just curious if there are discrepancies like that, who can we contact to confirm, and where do we send questions like that?
Send it to me.
Okay.
So I can directly follow up. I don't want it to get, not that I would. So we're getting questions from various angles. So if you get it to provider services, all Q&As are going into the same area. So we'll track it the same, but with stuff like that, I need to be able to respond quickly to the plan CEOs and administrators. So feel free to send those to me and I'll get them to the right place.
Thank you. We appreciate having access to somebody with some more answers, because I do agree that it would be best if there were a better way to access the call centers and the current email addresses. Even as of Friday, when I checked on the OHCA website, and then it directs us to those companies' portals or to their specific Sooner Select call centers or email addresses, that the email addresses either send you to an error code page, or they don't go through, or the phone numbers are not even answering yet and the voicemail's full. So that I think also increases the amount of questioning and
Absolutely.
frustration. And so we appreciate you being on the call this morning to help us, figure out and navigate the system as the changes are happening in our state. We did also have a few more questions, and if you could tell me a little bit more about those advisory boards that you mentioned, because occupational therapy specifically are advocates that we're the OKOTA association's trying to promote. Being on advisory boards with different groups. And I know the TBI advisory committee is being pushed through legislation right now. So we're looking at having someone familiar with TBI to be on that advisory committee for the governor. So if there's an advisory committee for each of the MCOs, is that what you said? How can we apply to help the companies as they're onboarding this new system?
So great question. I don't know, they're each going to have different selection criteria that they're using. And I don't know exactly what those are. Now, what we did was specify in the RFP which voices need to be at that table and what it should be comprised of. And so a lot of it's going to come out of their quality division, because it's going to be a continuous quality improvement initiative. And so what I would expect is, as they start onboarding their Oklahoma specific key staff, like a chief quality officer, for example, that's who will start developing these processes. So they're still in the process of bringing on their leadership staff. So as they fill that out, I would expect that they'll start reaching out, but definitely they'll look to associations. And so like if y'all haven't been connected with the plans yet at that level, then I'll be happy to connect you, Sarah, or through Julia to the various plan CEOs, because they'll be probably looking towards association membership to fill those.
That would be fantastic. I think this relates that we had a question, how they plan to ensure ESP DT compliance as they navigate to this new model, and what the agency has in place to supervise that.
So it's still a Medicaid benefit. And so all of our plans are extension of us. And so they have federal requirements to comply with EPSDT, just as we do. And so what I'm going to refer back to is the volumes of reports that we're requiring. So we are building out a Medicare, Sooner Select managed care operations component within the healthcare authority. So we're going to have a senior director over that with 4 or 5 managers that are just dedicated 100% to oversight, compliance, reviewing reports, making sure that they comply with all that stuff. And so one of which will be EPSDT. And so we'll track that through utilization information, claims extract, analyzing all the data we get, as well as what's submitted in those reports. There will also be, at the end of the day, we are the final arbiter of any grievances. And so if a member comes in and is with a grievance saying that they've been denied a service, for example, they'll start at the plan level. We'll give the plan the opportunity to resolve that grievance. But then if it's not resolved to the member satisfaction, they will then have a chance for a state fair hearing with the Medicaid agency for us to resolve that issue with the plan. Same with providers. Anytime a provider has a grievance about a plan, once they've exhausted remedies through the plan administrators, then they can come to the healthcare authority and we can resolve that using our criteria, just as now.
And then can you explain this a little bit better? Because there are 4 contracts is what we keep hearing for the therapy world to deal with.
Right.
However, aren't there a few more specialty plans that we may need to make sure that we're credentialed with? So for example, the DDSD or community-based waivers, so the adults with disabilities programs, or some of the other Medicaid specialty areas.
So those programs will be continued to be administered by their current administrator. And so if you are working with DDSD waiver services, that will continue the same process today. So we We are not transitioning any of our home and community-based waiver populations, developmentally disabled, or TEF for kids. Those will stay with the current administrator. So the only thing new to you will be those 4 medical plans. And like I said, Oklahoma Complete Health should have the same credentialing for their specialty plan.
Okay. We do have questions about caps and timelines, authorizations, but I'm not sure that we even have the answers to that yet, do we?
So I'll just defer back to, they cannot be more restricted than the healthcare authority is today unless we have specifically approved it. Same for their medical necessity criteria. So as far as implementation has gone down on that pathway, we haven't gotten to that point of implementation yet where we would receive and review. That's the floor that we're starting with.
Okay, and then we have a few people asking if you could please review. I know we covered this a little bit at the beginning, but there are terms that we're trying to use to describe changes like value-based or fee-for-service. And so if you could help us to know how to use the right words, because we will be discussing things with families. Families come to us and ask us for help to decipher the changes to their benefits. So if we could use the same terminology and understand what those terms mean to help our clients better understand their plans when they're making selections, that would be great.
So the first thing I would say that's going to be important is a client will have a different insurance card. And so right now they're used to having a healthcare authority sooner care card. They will have a card that says Blue Cross Blue Shield or Humana Horizons or Oklahoma Complete Health. And so it won't say sooner care card on it anymore. It will say Sooner Select somewhere. And so that will be the first change that a member notices as they go through the process. When it comes to payment, member safeguards are still in place. And so same cost sharing requirements are still in place, same cost sharing exemptions. And so kiddos and pregnant women still do not have co-pays, and that will exist in Sooner Select as well. So those same protections are afforded to our members even in Sooner Select. As far as performance-based payments, value-based payments, that shouldn't directly affect the members. But as we go into years 2 and 3 of managed care implementation, we'll start having the expectations that our plan will use various performance-based payments. And that's going to what that's going to look like is going to vary among the plans. But it'll be focused on outcomes and quality of service rather than just volume. And so they'll use various algorithms and calculations that we will work with them on and really incentivizing providers. And so I really think there's a good opportunity here for our providers who are used to providing quality services, seeing great outcomes with their clients, to actually fare better in a value-based payment environment than they do in a current fee-for-service environment.
And then once we have the contact information really up and going for the providers to ask questions specific to the plans, do you anticipate there being a little bit more of a marketing rollout? I know you guys have set up the town halls for us to access the panelists, but information like a PowerPoint presentation or maybe a small webinar from OHCA, so that people who maybe have just opened their own clinic and are just jumping into the therapy provider world right at this moment when everything seems to be changing, to provide some direction and help us to help the families better by knowing really what the terminology is, what our options are, kind of a timeline of what will be happening this year, that kind of thing. Do you know if OHCA's marketing communications department has plans to do that yet?
Sure. So we will have a model provider handbook that will kind of be give a broad overview of Sooner Select, and then it'll really be up to the plans to give really specific handbooks and technical assistance and guidance. There's requirements that they have actually on an annual basis. I want to say at least quarterly regional town hall type meetings. Each plan will be required to do that. So if I had to guess, that'll be in conjunction with us, very similar to the process we're using now, but really more plan specific and plan focused, where they're actually working with providers directly. So there's going to be this transition period where we're still working with our providers, helping them educate, but there's going to be an expectation at some point that those plans are really taking the lead on technical assistance. They'll have regional TA folks, just like we do provider education specialists, that we expect and will require them to come to your office, walk you through their portal, how to use it, and provide more targeted TA through that avenue as well.
So the dates that we've heard so far this morning are August and October. Could you review that again with us? Because as we're receiving contracts and being asked to sign them, but the information's really not quite there yet for us to read through manuals, et cetera. How should we help our members and the business owners that have been asking questions of us? How can we direct them to find that information? Or do we need to ask them to be patient as the providers are getting that information out to the public?
Yeah, so right now I would say be patient. And so what I'm trying to do is just say, I understand everyone's fears. I understand a member level fear. I understand providers' fear. And trust me, smooth implementation is what keeps me up at night, and it will until October the 2nd. But we will send our initial round of letters out to members July 1st. And that letter will say, we're transitioning to third-party managed care. You'll have an option to choose from. Call these 1-800 numbers. It'll get you to the Healthcare Authority Choice Counselors. They will show you a benefits comparison guide that shows you the various value-added benefits that each plan offers that maybe the other one doesn't, in addition to base benefits that they all require. And so that's when our initial mailings will go out. And that's when you may want to be prepared for members coming in saying they got a letter, like, what is this? And we'll do our best to also send copies of that or notices of it to our providers so that they're prepared as well. And then August 1st is when, so we're sending that out a month early so they can start calling in, getting their counseling. And then August 1st is when we'll start allowing the plan selection. So they'll actually choose which plan they want to go with. What I've seen in experience from other states is anywhere to 20 to 30% of folks will actually choose a plan in that first month. And then the rest will be auto assigned. So then we expect a lot of calls to be generated from an auto assignment letter from members saying, why did you give me Blue Cross Blue Shield? And so then we'll walk them through what their options are at that point. And again, they have that 90 days to enroll. That's just initial enrollment. In prior years, open enrollment will begin in May of every year. So May 1st will be open enrollment, and that way they're aligned with the plan July 1st. The reason we did that is it aligns with the state fiscal year. So we want our plan year to align with the state fiscal year. So this first year is going to be fairly short as far as plan year goes. We've also had questions around what happens if a plan isn't ready to go live October 1st. So we have built in safeguards in our timeline. So first of all, we're working with them on a daily basis. And so we're already going to have a good idea of which plans aren't ready to move forward or which plans are kind of lagging behind the other ones. And so we'll know well ahead of this, but our first checkpoint is going to be around July 1st. That's when, adequate networks are going to be required already. Our staffing plans for each plan will be ready. And so we'll have a good idea at that point who's really lagging behind and who's, good to go. But September 1st is kind of our drop dead for, because we still require CMS approval for this. Our federal partners, they have to approve the waiver that allows for a managed care service delivery system. They have to approve all of our contracts with our new partners. They have to approve all of the rates that we're paying them, making sure that they are actuarially sound. Even though we've done our legwork, at Oklahoma, that they still have to approve all that. And so if we don't have CMS approval by 9/1, then we're hitting pause. And so the next viable option after this time, if we hit pause due to no CMS approval, will be January 1st of 2022. And so we've set that as September 1st because we need that month to really notify providers, notify members, say we're changing direction. We've seen other states where CMS notified them about 10 days prior to go live that the state wasn't ready to move forward. And so that's not enough time to do anything. And so we've tried to give ourselves that month cushion. 9/1 will also be our drop dead date for is an individual plan ready or not. So let's say that one plan just isn't ready, their call center isn't ready, or they don't have an adequate network, or they are not fully staffed yet. At that point, we'll say, okay, plan ABC, you don't get to move forward. In other words, there's several options we can use there. If I had to guess, the option we'll use is that plan will be held back and then won't be eligible to come back on until the next open enrollment cycle, which would be May 1st. And so I think that plan would have to evaluate if that's financially viable for them because they won't get auto assignments then. It would actually have to be members choosing to go with plan ABC at the May 1st open enrollment, which leads me to, and I think I saw a question around this in the stuff Julia sent. plans are strictly prohibited from marketing to members. It's a federal law. They can't directly solicit members. And so it's not going to be one of those deals where a member is getting a packet from Humana in the mail saying, hey, sign up with us because we offer you this, this, and that. And, every open enrollment, it's a, fight for marketing for members. That is strictly prohibited at the federal level. And so the only counseling they can get in terms of outreach for the plans is from either a designated call center of ours or healthcare authority employees or providers that want to walk them through their benefits. But we will plan to put the benefit comparison guide online so members can access that, as well as, talk through it with our choice counselors.
That's helpful, that information. I'm going to have to take a few minutes to process all that, but it's good to know that that from the feedback you're getting, you're trying to make contingency plans just in case. Speaking of contingencies, is there a chance that there's anything that might cause a delay in this in terms of, some of the groups that are advocating against it even going forward at all? Or if we go ahead and fill out contracts with certain companies, but then they pull out and we end up needing to find, if our contracts are going to be good with another MCO coming in. So do you have some information about that?
Sure. And so, there's kind of a couple of things. So legislatively, there's stuff going on. What I would say is we've not requested additional funding for managed care. We're using current Sooner Care funding and just transitioning that from a fee-for-service model to a managed care delivery model. And so that we're not actually paying managed care companies more to manage the care. And so there are a couple of bills out there that could affect it. From what I'm hearing, I'm not sure that that's really going to have an impact as we move forward. There's also a there is also a lawsuit out there where they've asked for injunctive relief that would prevent Oklahoma from moving forward. That has to be heard by the Oklahoma Supreme Court. It has still not been heard as of yet. What I would say is from a provider standpoint, there would be none that I can think of any detrimental effects if you go ahead and sign with the provider. You mentioned a new provider coming in. So let's say you go ahead and contract with all four. And if something happens to where the state is enjoined or prohibited from moving forward, we would just hit pause and you would still have your contract with the healthcare authority and all your PAs and payment would still process to the healthcare authority until we take our finger off the pause button. But you're already then contracted and credentialed with those plans and we'll be ready to go whenever we do implement. There is not going to be an opportunity for a new plan to enter at this point. So let's say you credential and contract with four and then something happens and then we pull in a surprise plan at the last minute. That won't happen. We've already gone through the RFP process and awarded those to our partners. Now, what may happen is you contract with all four and then one isn't ready and they pull out or they go to the next open enrollment period. But that won't affect you. It'll just mean that those clients that were with that plan will have the choice to choose one of the three remaining plans or be auto assigned to one of the three. But if you're contract with all of them, again, process will be seamless.
Do you know how often that members will be able to change their plan?
So in the initial period, you can change, I believe, multiple times within the first 90 days. After that 90-day period, then you are locked into that plan until the next open enrollment.
Okay, that's good to know because we frequently spend administrative time in our billing offices working out the differences in the plans and the benefits when we have families that switch. Related to that, what will happen per se because this does happen frequently, if a family has commercial insurance primary and they've had Medicaid secondary. So if they will then be on a BCBS commercial plan primary and then a BCBS Sooner Select plan secondary, will it be a similar issue where we're waiting for the primary benefits to run out or to be denied and then the secondary will kick in? Do you anticipate it being a similar situation?
Yeah, the third party liability piece will still be very similar.
Okay. I'm going to look through the chat because we have a few minutes left and I appreciate your time and going through this. We've had multiple questions that kind of repeat the same theme, that we're really looking for information about how to contact the MCOs and then also timelines for authorization for services. I think there's been enough interest in those topics that OKOTA may try to also provide something on our website, Q&A, if we could, from today's information and from what we've gathered from the town halls to help our members to answer those questions. Do you know if OHCA is planning to add some information to the 2-page flyer that's available on the website right now? That's really a general introduction, but maybe something specific for providers to get more information, right at your website.
Sure, we can, and we're always open to feedback on how those materials can be better. So if there's something you feel that we're lacking, we're happy to add that. I'm trying to think if I addressed in and out of network. So as you were talking, I was thinking about, just as you do now with your commercial payers, you tell your clients, here's who we contract with. And so as they're coming in and they're having questions, you can tell them we're contracted with Blue Cross Blue Shield and Humana, for example, and that will help them make their choice. Now, if you're not contracted, that just means you're out of network. And I believe we set the fees for out of network because it can't be any less than 95%. And so if you see a client that's on Sooner Care, but you don't contract with like United, for example, then you would be paid as an out of network provider, which cannot be less than 95% of their fee schedule.
That's good to know. That may also be helpful with the transition time as we're getting all of the paperwork done and figuring out the details of all the staff. We did have a technical question, and if you don't know, we'd be happy to get the answer out to our members later. And a lot of clinics have behavioral health counseling and pediatric therapies available, or we also see adults over the age of 21. So if we have all of those different groups in one facility, does the facility have the chance to register as a group provider with the managed care organizations, or will we need to just credential each provider individually the way that each provider is typically approved through OHCA, but then we can also bill under a group NPI?
So I'm pretty sure we still will require renderings because that's more of a CMS requirement. And so they've asked for some flexibility, and I'll have to follow up with our provider engagement director over that. But I'm pretty sure you still will credential us very similarly, because remember, you're still going through the healthcare authority first. And we require all those renderings to be aligned with the group ID. Now, what I heard was some of these independent LBHPs are serving adults currently, which is not a covered Sooner Care benefit, but there is opportunity for our plans to provide as a value added benefit coverage for an adult, for example, by an independent LBHP, whereas Sooner Care does not pay for that. So keep in mind, there's actually opportunities for more and different reimbursable opportunities through Sooner Select. That doesn't mean we pay the plan anymore per member per month. It just means that they recognize it as a value and it's added benefit that will actually help individuals achieve better outcomes.
Well, that's encouraging. We do also have clinical fellows, speech pathology clinical fellows, or unlicensed qualified providers. So if you've heard anything from them yet about this, a lot of the paperwork we're currently receiving, like you said, may be a little out of date, or it may be based on the commercial package, not necessarily with all the details from your requirements at OHCA. So if we have, for example, licensed professional counselors, or if we have candidates, or if we have the other provider types who may not necessarily have a independent license yet, will those still be able to provide services with the new managed care plans?
Yes, they have to recognize everyone that we currently contract with. Now, I received a question, I think last week, for example, around, I think, a plan telling a candidate, okay, you can still bill, but you have to bill through your supervisor using a certain modifier. And so now I'm working with the plans on, that's not really the way we do it. We capture individual renderings on that. We stopped using modifiers probably 8 years ago on that piece. So we're working with the plans on that. Some things we're running into is they are all, I think, like NCQH accredited as an insurance plan. And some of that, it comes down to their accrediting entity. And so we'll work through issues like that, but they should be able to, they're required to contract with everyone we contract now. So there's that first piece. The second piece we'll work through is, what does that look like in a managed care environment? Will they require you to bill through a supervisor, for example, or will you still keep billing the same way? And so we'll work through that. We plan to, we're collecting, like, as I said, a master Q&A document. Most of them are plan to OHCA related, but as we come across provider FAQs, my hope and expectation is that we'll start publishing those. So a lot of these questions that we're getting will be in a FAQ bank that providers can access.
That would be very helpful. We'll look forward to seeing that and helping contribute to it where we can. The out-of-network benefit and RFP caps and different things like that, will that information be available to providers? Is that something that you would just prefer maybe people get those questions answered through the associations who are in contact with you as things change? What would your recommendation be?
Well, my unrealistic expectation is everyone read the RFP because it is pretty comprehensive and it covers all that. And so I don't know. I'm surprised Julia hasn't put you a fact sheet together yet.
Oh,
Maybe I can work with her on doing that. But we can put our trouble, our quandary is there's so many different specialists and provider types that it would be hard to create fact sheets for each of those. But again, I encourage, if you go to our Sooner Select website, pull up the RFP. It's daunting, yes. But if you do a quick search around your provider type, chances are it'll take you right to that one paragraph that talks about physical therapy, for example, or caps or reimbursement.
okay, thank you. We'll be sure to put links to that document up on our website and perhaps do some social media blasts in the next couple of weeks as we celebrate Occupational Therapy Month in April. And then a lot of our clients that we work with also have days of recognition in April. So we'll be doing some extra marketing and education from the OT Association as well. I know it's almost 10 o'clock and we really value your time. I just want to say thanks again for coming on today and helping us to direct a lot of the questions that providers have been sending our way to the right place, that we know where we can get some information, and then also working with OHCA as we move forward, because we do want to provide continuity of care to the members, and we do want our business owners to be successful as we go through the process. And I know there are some things still up in the air and some changes may happen probably will happen between now and August and October. So we appreciate your time in working with the therapy associations and helping our members.
Of course. Yeah, I'm happy to. And just a reminder, we all keep forgetting, or maybe not, but we're still expanding Medicaid July 1st. So that's happening too. And we plan to put resources out soon on our website around, printable flyers, posters for your offices, how-tos on directing to mysoonercare.org. So don't want anyone to forget about, Medicaid expansion as well.
We're keeping an eye on that. We have occupational therapy in the CCBHCs and in the acute inpatient psych and community health centers. And occupational therapy is in a lot of places. So along with our speech therapy and PT colleagues, we're looking forward to that.
Awesome. All right. Well, yeah, if you want, communicate, Sarah, if you want to with me or through Julia, send me your questions if you want to keep collecting them, and we can get your responses back in writing if that's helpful too.
We do. We have a second page almost ready to send you.
Awesome. I'll be looking forward to it.
Thanks, Taylor.
Bye.
Bye-bye. For those of you that are still on the call, you're welcome to continue to put questions into the chat. I will take a few in-person questions if you're available to do that at this time. We have about 5 more minutes and we can do a little bit of live Q&A if you'd like to help me put together more questions, specific questions for OHCA like we had today. I think there were quite a few questions answered, but there may be several more that we didn't get to yet. So if you have a quick question for the group and for us to consider moving forward for the associations doing advocacy for our members, please include that into the chat for me to have a record of it. And then once we have permission, we just want to get confirmation that it's okay to have a recording available for our members to review all this. There was so much detailed information and it did go by pretty quickly. So we want to be able to provide that to our members if possible. Once we have confirmation, we'll email everybody that signed up for the Zoom meeting today and make it available for members once that's confirmed. So if you have a question, if you could raise your hand on the icons.
Sarah?
Yes, I can hear you now.
Oh, okay. I'm very curious what he was saying about the out of network benefit. Did you hear that he said 95% they would pay? That is a very high percentage for an out of
Uh,
network.
I noticed that as well, and so I'm going to go back to the OHCA website and confirm that that's in the RFP, or if that's somewhere else, so that we can direct providers to that. I think that will help us make a determination if we're not comfortable signing a legal document yet, if we don't have all the information available that we would want to have when we're working on a contract with a company, that perhaps that would be okay for a transition time period if it's going to be that that number. So that's definitely something we want to confirm.
That was really good news is what I'm thinking. So.
That was helpful, wasn't it? Do we have any other questions this morning?
I just, speaking to that out of network, I'm totally new to this whole managed care organization. You think the pre-authorization would be the same? Did you talk about that or did I miss it?
So it's similar. I have a
Okay.
feeling they don't know the details quite yet because it will
Okay.
be plan specific. That
Okay,
is something that we're trying to encourage. And when he mentioned that there would be an advisory committee for each of the managed care organizations, that's something that as the OT Association president, I wanted to jump on that specifically, because if we have qualified providers that are on those advisory committees, I think that will help everyone because the communication would be there for sure. So the OT Association will be looking into that and how we can help. If you're interested in serving on an advisory committee, if you're interested in that type of a position to help us transition to this new kind of a managed care plan organization style, then let me know. If you'll send me an email at okotapresident@gmail.com. If you'd be interested in getting information about where and when and if those happen, then we'll have a short list available to send to the CEOs, and that could be very helpful. If you're OT, PT, speech, whichever profession that you are, it'd be beneficial to have those qualified providers available to be on an advisory committee, in my opinion. I think we have time for one more question, and then I have a staff meeting to go to. All right. Thank you, everybody, for coming to the meeting today. I think we were well represented, and we did get a few of our questions answered specific to the therapy services today. We will continue to work together and advocate for more data, for more assurances, and we'll keep an eye on the whole process that's going on statewide with different groups who are advocating for our careers, for our businesses, for our patients, for our families. Thank you all for being a part of the meeting today. I appreciate your time and your feedback. Thank you for sending in your comments and questions to the chat section, and we'll put together some resources to help get this information out, and then also to give more questions to Mr. Rains at OHCA. Thank you.